This conference will now be recorded.
Hello, everyone. A warm welcome to CM Dental Academy. It is an online dental education platform in the field of dental surgery. We aim at delivering excellent quality online training programs and courses for dental students under the guidance of eminent mentors. The subjects will be covered in all the formats such as live lectures, descriptive notes, MCQs, and Viva Voce questions. So, what are you waiting for? Come, let's begin a journey towards success. Myself, Dr. Mayuri Kulkarni Patil, MDS in Oral and Maxillofacial Pathology, Course Director at CM Dental Academy. Today, we'll discuss a very important and interesting topic, enamel hypoplasia. A question is being asked in your previous university exams many times as classify enamel hypoplasia, discuss about environmental enamel hypoplasia. It's been asked as a long essay. Enamel hypoplasia may be defined as an incomplete or defective formation of organic enamel matrix of teeth. This is being the definition of the enamel hypoplasia, and it has to be the it is a very important. So I want you all to sit with the notepad and a pen so that whenever I'm just mentioning any important Viva questions or definitions or any classifications, you can just note them down just to revise you a quick revision for you all during your university exams. Need not to go through the entire presentation or the textbook. Broadly, enamel hypoplasia is classified into two types, hereditary type and environmental type. In hereditary type, both deciduous and permanent dentitions are usually involved, and enamel is mostly affected. Types caused by environmental factors, either dentition are involved and sometimes only a single tooth, but both enamel and dentine are affected to some extent. The cause for enamel hypoplasia being the injury to the ameloblast. Broadly, the factors which may give rise to the condition are as follows. Nutritional deficiency, mainly vitamin A, C, and D. Exanthematous diseases such as measles, chickenpox, and scarlet fever. Measles is an acute contagious dermatotropic and endemic viral infection primarily affecting children caused by paramyxovirus, which is a RNA virus. The characteristic intraoral lesions are called as Koplik spots. It's also very important in Viva point of view. Chickenpox is also called as varicella, caused by varicella zoster DNA virus. It is the acute, ubiquitous, and extremely contagious disease usually occur in children. Exanthematous vesicular rashes are characteristics of the chickenpox. Scarlet fever is also known as scarlatina. It is a contagious systemic bacterial infection, occurs predominantly in children. Scarlet skin rashes giving sandpaper feel to the skin are the characteristics of scarlet fever. This is also a very important Viva question. So vitamin A, it is a fat soluble vitamin. It is mainly associated with vision and lysosomal stability. Have a hormonal function in regulation of epithelial differentiation. Intracellular receptors have been identified and may transport vitamin A molecules to the cell nucleus where they interact with DNA to direct cellular differentiation. This is being the function of the vitamin A. So whenever there is a deficiency of vitamin A in the body during the formation of the enamel, it leads to the defective cell differentiations of the ameloblast, and further it leads to the enamel hypoplasia. Vitamin C is a water-soluble vitamin. It is required for the normal development of intercellular ground substance. especially in bone, dentine, and other tissues. Congenital syphilis. It is caused by Treponema pallidum, a spirochete. Congenital syphilis is transmitted to the offspring only by the affected mother. Hypocalcemia is a decreased calcium level in blood. Birth injuries, prematurity, Rh hemolytic diseases, local infection or trauma, ingestion of chemicals, mainly fluoride, idiopathic causes. It presents a mild environmental hypoplasia with only the small grooves or the pits or the fissures on the enamel surface. In case of severe type, rows of deep pits arranged horizontally across the surface of the tooth, maybe only a single row of such pits or several rows indicating a series of injuries. In most severe cases, a considerable portion of absence of enamel suggesting a prolonged disturbance in the function of the ameloblast is seen. A picture of a ground section showing a pitting on lingual and the labial surface of the tooth. Here you can see the pitting of the enamel on lingual and labial surface of the tooth. In this picture, you can see the stained pits along the labial surface of central incisor, lateral incisor, and canine. It occurs during the time the teeth are developing, more especially during the formative stage of enamel. But once the enamel is calcified, no such defects can be produced. Thus, knowing the chronologic development of the deciduous and permanent teeth, it is possible to determine from the location of the defect on the tooth the approximate time to which the injury has occurred. Hypoplasia due to nutritional deficiency and exanthematous diseases. Rickets. During the time of tooth formation, it is most commonly known cause of enamel hypoplasia. Rickets can be defined as any disorder in vitamin D calcium phosphorus axis which results in hypomineralized bone matrix, that is failure to the endochondral calcification. Vitamin A and C, which I have explained you earlier, how they affect the enamel hypoplasia. Exanthematous diseases such as measles, chickenpox, and scarlet fever, and any serious nutritional deficiency or systemic diseases. Ameloblasts being the most sensitive group of cells in the body in terms of metabolic function, the type of hypoplasia occurring from these deficiency or disease states is usually the pitting variety. Since the pits tend to stain, the clinical appearance of teeth may be very unsightly. Clinical studies indicate that most cases of enamel hypoplasia involve those teeth that form within the first year after birth, although teeth that form somewhat later may be affected. So, which are the teeth most commonly involved in enamel hypoplasia? Very important question for Viva. And why they are involved? The central incisors, lateral incisors, cuspids, and the first molars. Since the tip of the cuspid begins formation before the lateral incisor, some cases involve only the central incisor, cuspid, and first molar. Premolars, second and third molars are seldom affected since their formation does not begin until about the age of 3 years or later. There has been considerable controversy as to whether there is any relationship between enamel hypoplasia and dental caries. It is most reasonable to assume that the two are not related, although hypoplastic teeth do appear to decay at a somewhat more rapid rate. Enamel hypoplasia due to congenital syphilis. Congenital syphilis, it presents with a characteristic pathognomonic appearance whenever it shows enamel hypoplasia. Teeth involved mainly are maxillary and mandibular permanent incisors and the first molars. Anterior teeth affected sometimes are called as Hutchinson's teeth. Note it down. and mulberry molars. These are also called as Boon's molars and Fournier's molars. Why there is a characteristic appearance of a screwdriver shape to the teeth? The reason being the mesial and the distal surface of the crown tapering and converging towards the incisal edge of the tooth rather than towards the cervical margin. In addition, incisal edge is usually notched. Why it is notched? Because there is an absence of central tubercle or calcification center. The mandibular central and lateral incisors may be similarly involved, although the maxillary lateral incisor may be normal. In case of molars, the crowns of the first molars in congenital syphilis are irregular and the enamel of the occlusal surface and occlusal third of the teeth appears to be arranged in an agglomerate mass of globules. You can see here a molar picture showing an agglomerate mass of globule rather than a well-formed cusps. The crown is narrower on the occlusal surface than at the cervical margin. Not all the patients with the syphilis will exhibit these characteristic findings. Hutchinson's teeth, mulberry molars. Where they are seen, why they are seen. Enamel hypoplasia due to hypocalcemia, that is reduced calcium in blood. Tetany induced by a decreased level of calcium in the blood may result from several conditions such as vitamin D deficiency and parathyroid deficiency. In tetany, the serum calcium level may fall as low as 6 to 8 milligrams per 100 ml. And of this level, the enamel hypoplasia is frequently produced in teeth developing concomitantly. This type of enamel hypoplasia is usually of pitting variety and thus does not differ from that resulting from nutritional disturbances and exanthematous diseases. Hypoplasia due to birth injuries. Neonatal line or a ring described by Scour in 1936 is present in deciduous teeth and first permanent molars. May be thought of as a type of hypoplasia because there is a disturbance produced in enamel and dentine which is indicative of a trauma or change of environment at the time of birth. In traumatic births, the formation of enamel may even cease at this time. Enamel hypoplasia is more common in prematurely born babies than in full-term infants. It occurs in children who have suffered from Rh hemolytic diseases at birth in addition to widely recognized staining of teeth. Although the literature indicates that most cases of enamel hypoplasia of deciduous teeth involve enamel formed after birth. It is seen also in prenatal enamel. In such instances, gastrointestinal disturbances and some other illness in mother may be responsible. Enamel hypoplasia due to local infection or Turner's teeth or Turner's hypoplasia. A type of hypoplasia occasionally seen involving a single tooth, most commonly one of the permanent maxillary incisor or maxillary or mandibular premolar, ranges from mild brownish discoloration of enamel to severe pitting irregularity of the crown. These single teeth are frequently called as Turner's teeth. Again, a point to be noted, and this condition is called as Turner's hypoplasia. Pictorial presentation of a radiograph showing a defectively formed premolar tooth. Rather than showing a proper cusp development, a deformed premolar is being formed. And it is a characteristic feature of Turner's tooth or Turner's hypoplasia. If deciduous tooth becomes carious during the period when the crown of the succeeding permanent tooth is being formed, the bacterial infection involving the periapical tissues of the deciduous tooth may disturb the ameloblastic layer of the permanent tooth, which results in a hypoplastic crown. The severity of this condition will depend mainly on the severity of the infection present in the periapical region of the deciduous tooth, the degree of tissue involvement, to what extent it is spreaded or associated with, and the stage at which the permanent tooth formation is going on. A similar type of hypoplasia may follow trauma to the deciduous tooth, particularly when the deciduous tooth has been driven into the alveolus and disturbed the permanent tooth bud. This may affect either the matrix formation or calcification, depending chiefly on the stage of tooth formation at the time of injury. If this permanent tooth crown is still being formed, the resulting injury may be manifested as yellowish or brownish stain or pigmentation of the enamel, usually on the labial surface, or as a true hypoplastic pitting defect or deformity. Enamel hypoplasia due to fluoride, it is also called as dental fluorosis, and it presents with the mottled enamel. This type of hypoplasia was first reported by G.V. Black and Frederick Mackey in 1916. Earlier reference to the condition is known in the foreign literature. However, Black and Mackey recognized that this lesion exhibited a geographic distribution and even suggested that it was a result of some substance in the water supply, although it was not until some years later that fluorine was shown to be the causative agent. It is now recognized that ingestion of fluoride containing drinking water during the time of tooth formation is the result of mottled enamel. The severity of the mottling increases with increasing amount of fluoride in water. There is a little mottling of any clinical significance at a level below 0.9 to 1 parts per million of fluoride in the water, whereas it becomes progressively evident above this level. There is a disturbance to the ameloblast during the formative stage of the tooth development. The exact nature of injury is not known, but since there is a histologic evidence of cell damage, it is likely that cell product, the enamel matrix, is defective or deficient. It has also been suggested that with somewhat higher level of fluoride, there is interference with the calcification process of the matrix. Epidemiologic studies have reported that not all the children born with endemic fluorosis exhibit same degree of mottling even though they use the same water supply. It depends on a person. Sometimes they may exhibit mild mottling even when they are exposed to the low concentration of fluoride. These findings may be related to individual variation in total water consumption and thus total fluoride intake. Clinically, it presents with the mottled enamel and has been reported in many parts of the world such as Europe, Africa, and Asia, as well as United States. Depending on the level of fluoride in water supply, there is a wide range of severity in the appearance of the mottled teeth. Questionable changes, it is characterized by occasional white flecking or spotting of the enamel. Mild changes manifested by white opaque areas involving more of the tooth surface area. Moderate and severe changes show pitting and brownish staining of the surface and even a corroded appearance of the teeth. And those teeth which are moderately or severely affected may show wearing and even fracture of the enamel. Here picture A and B shows the enamel surface by the white opaque areas. These are the white opaque areas presented on the incisor, lateral incisor, canine and bicuspids. And C and D shows Severe pitting. You can see here the severe pitting of the teeth, central incisors, even lateral canines, lower bicuspids, and there is a obvious staining present on the incisor teeth and the lower incisors also. Early studies actually noted the difficulty in restoring these teeth. Treatment of mortal enamel frequently is being bleaching of the tooth with the hydrogen peroxide. This is frequently effective, but the procedure must be carried out periodically since the teeth tends to stain regularly. Enamel hypoplasia due to idiopathic factors. Even with the careful histories, the majority of the cases are of unknown origin. Since the amyloblast is a sensitive type of cell and easily damaged, it is likely that in these cases in which the etiology cannot be determined, the causative agent may have been some illness or systemic disturbance so mild that it made no impact on the person or a patient, and it was so negligible that patient is unable to remember or point it out. Even relatively severe cause of enamel hypoplasia arise with no pertinent past medical history to account for their occurrence. Molar incisor hypomineralization. It is a developmental defect due to the environmental changes that affect the enamel, leading to permanent damage of the first permanent molars and incisors. This condition is also known as non-fluoride enamel opacities, internal enamel hypoplasia, non-endemic mottling of enamel, opaque spots, idiopathic enamel opacities, and idiopathic enamel hypomineralization. These are all the synonyms for molar incisor hypomineralization, commonly asked during your Viva exams. It is defined as the clinical appearance of the morphological enamel defect involving occlusal and or incisal third of one or more permanent molars or incisors as a result of hypomineralization of systemic origin. The etiology behind the alterations caused in molar incisor hypoplasia is not fully understood, and it is uh, thought to be localized and asymmetrical presentation due to the disturbance in processing during early maturation or late secretory phase. The most probable causes being the environmental changes, severe malnutrition, maternal diabetes, systemic diseases, use of antibiotics, mainly amoxicillin in febrile illness, respiratory and infectious diseases. It is also been reported to have a genetic predisposition association with a range of systemic insults to the sensitive amyloblasts. This explains the pattern in which few of the teeth are affected and few remain unaffected. The clinical features, it shows enamel defects of one or more first permanent molars. Altered enamel may be white, yellow, or brown with sharp demarcation between defective and surrounding normal enamel. Involved enamel is soft and porous with resemblance to the discolored chalk or Dutch cheese, or these are also called as the cheese molars. Please note it down. Frequently, incisors are also affected, but with less severity. Enamel is very fragile and can chip easily. Affected molars are sensitive to cold, warm, and mechanical trauma. Frequently, painful toothbrushing leads to rapid development of caries. Teeth are highly sensitive and very difficult to anesthetize during dental appointments. Enamel hypoplasia caused by anti-neoplastic therapy. It is due to radiation and chemotherapy, commonly younger than 12 years and most extensively in those children who are younger than 5 years of the age are receiving radio or chemotherapy for the cancer. The degree and severity of the developmental disturbances are related to the age of the patient, the form of therapy, dose and field of radiation. Most severe alterations are associated with the radiation. The doses are as low as 0.72 gray are associated with mild developmental defects in enamel and dentine. Frequent alterations other than this also includes hypodontia, that is decreased in the number of the teeth, microdontia, reduced in the size of the tooth, radicular hypoplasia, enamel hypoplasia, mandibular hypoplasia is decrease in the size of the jaw, reduction in the vertical development of the lower third of the face. So with chemotherapy, enamel hypoplasia shows discolorations, slightly smaller tooth size teeth, and radicular hypoplasia. In nutshell, I just want to put enamel hypoplasia and the discussion about environmental enamel hypoplasia as follow. First, let's begin with the introduction and the definition. Broad classification, two types. Then begin with the environmental enamel hypoplasia. Based on the causes, it is being characterized as hypoplasia due to nutritional deficiency and exanthematous diseases, due to congenital syphilis, hypocalcemia, birth injuries, local infection or trauma, due to fluoride, idiopathic factors, molar incisor hypomineralisation, enamel hypoplasia caused by anti-neoplastic therapy. So it should be these all the factors should be discussed in detail. The way, what is the causative agent for the enamel hypoplasia? How do they represent? That is the clinical features, and in general, what has to be done to treat the patient if patient comes to you with the enamel hypoplasia. So this was my contribution towards your study journey. CM Dental Academy is coming up with the module 1 for the oral pathology. The highlights being 25 live lectures, session recordings, targeted revision at the end of the module, online notes, viva voce questions, MCQs, important slides will be discussed, and free access to the libraries. It is going to be a cakewalk for you all. So let's grab the opportunity and book your slots. Per batch, very limited seats will be available so that personal attention will be given to the students. The chapters being covered in first module being developmental disturbances, oral and paraoral structures, cysts and orofacial region, odontogenic tumors, epithelial tumors of oral cavity, non-epithelial tumors of oral cavity, tumors of salivary glands. So all the neoplastic and non-neoplastic lesions, main important topics will be covered in first module. So for further details, please dial to the above mentioned number. I conclude, your future depends on what you do today, and your today has already started. Thank you.